Hello and welcome to our session today. It's always a pleasure having you in our presentation. Today we are going to look at the disorders of the respiratory system. So the respiratory system, in this case, we have objectives. We look at the anatomy and the physiology, look at the assessment, and then review the management of different respiratory disorders. So, starting with the anatomy, we find that the respiratory system is composed of two major sections. We have the upper and the lower respiratory system. So together, these two tracts, they are responsible for ventilation, which is simply defined as the movement of air in and out of the airways. The respiratory system has major functions. So we have the upper portion, that's the upper respiratory tract, whose major function is to filter air, moisten it, and warm the air during the inspiration. The lower portion, which is majorly made up of the lungs, is responsible to enable the exchange of gases between blood and into the air, just to regulate the partial pressure of both carbon dioxide and oxygen together with the pH of the body. When you look at the upper respiratory system consists of the nose, the sinuses, the nasal passages, the pharynx, the tonsils, the adenoids, the larynx, and the trachea, and they are represented here on our diagram. The lower respiratory tract is made up of the bronchi and the lungs. Starting with the nose and the mouth, they do allow air to get in to flow out and in of the body, and the nose normally humidifies inhaled air. So when the air is humidified, it normally reduces irritation of the mucous membrane. The major functions of the nose will include providing a passage for the incoming and outgoing air by filtering, warming, and moisturizing it. And also it provides an organ of smell. So we have the nares, those are the nostrils that do contain olfactory receptor sites. So this one, they provide the body with a sense of smell. In terms of pathology on the nose, we have an area which is characterized by the blood vessel endings, and it's referred to as the little area. This area is prone to epistaxis, which is commonly referred to as nose bleeding. The second part is then paranasal sinuses, and paranasal sinuses are named after the bones that they do contain them. So we have the frontal bone in the lower forehead, the maxillary in the cheekbones, the ethmoid beside the upper nose, and the sphenoid behind the nose. So these are the four bones that we have, the paranasal sinuses, and they're commonly abbreviated as the MEFs. So these paranasal sinuses are fluid filled, they are air filled, they are cilia lined cavities within the nose. Their major function is to trap particles of foreign matter that might interfere with the respiratory system or cause an infection. The most common pathology associated with this anatomical area is sinusitis. The third is the pharynx is the third anatomical region, and this pharynx consists of muscles with mucus lining. So it has regions that are three. The first one, we have the nasopharynx, followed by the oropharynx, and lastly laryngopharynx. In nasopharynx, this one is normally found behind the nose, and it opens into the eustachian tube and does contain nasopharyngeal tonsils and adenoids. Oropharynx is the second part, and it forms the archway behind the mouth. It also contains the palatine tonsils, and the common disorder associated with this pharynx anatomical region is pharyngitis. Let's remind ourselves about the last part of the pharynx, which is the laryngopharynx, which does open into the esophagus and the larynx. So that takes us to the function of the pharynx, which number one, we are saying that the pharynx serves as a passageway into the digestive and respiratory tract, and it also maintains air pressure in the middle ear, and this is more associated with the nasopharynx, the first part of the pharynx. It also contains a mucosal lining that continues the processing of humidifying and warming inhaled air in addition to trapping the foreign particles. It also helps in phonation. We also have tonsils. Remember we talked of the oropharynx containing the tonsils, and these tonsils, they do aid in destroying incoming bacteria. The fourth region is the larynx, and the larynx contains vocal cords, and that's why it's referred to as the voice box, right? The larynx is located at the upper end of the trachea and just below the pharynx. So the larynx connects the upper and lower airways. It's formed by the cartilage network, and the first one is the thyroid cartilage, commonly referred to as the Adam's apple, followed by the epiglottis, which is the lid cartilage, and lastly the cricoids, which is the signet ring cartilage. So we have regions of the larynx. Where we have the first one, the supraglottis, and then the glottis and the subglottis area. Okay, so this larynx, we've said it has vocal cords, which in this case we could have the false cords, which are the folds of the mucous lining, and the true cords, which are the fibroblastic bands stretched across the hollow interior of the larynx. The larynx helps initiate a cough reflex. This is part of the respiratory system defense mechanism to detect and remove foreign intruders in that system. It also contains the vocal cords that do help in producing sounds. We have the trachea as our fifth region, and the trachea has walls that do contain C-shaped cartilaginous rings, which are majorly made up of hyaline cartilage. And they are composed of smooth muscles that does keep the tube open at all time through the bronchodilation. Okay, so its lining is composed of the ciliated mucosa, and it does extends from the larynx around the C6 region to the bronchi, where the trachea bifurcates around the T5 region, right? In terms of its length, it's about 10 to 12 centimeters long. The trachea branches into the right and left bronchi at the level between T4 to T5. And you find that the bronchi are large air passages that leads to the right and left lungs. All right, so we're looking at that sternal ankle or region. The right main bronchus is slightly larger and more vertical, and it's short than the left one. So the risk of aspiration and foreign body obstruction is very prevalent and prevalently associated with the right bronchus. If you accidentally swallow and something gets into the respiratory system, that item is likely to be found in the right bronchus. Even this concept is very critical when you're carrying out resuscitation of patient, because when the patient are still unconscious but their breathing is okay, we normally put them in recovery position and we do the left recumbent position, right? Because if you put them on the right bronchus is larger and more vertical, so aspiration is likely to happen in that. So the left main bronchus is longer and narrow and more horizontal, and of course that is a plus for us when we're putting the patients on the left side. So the bronchi form small branches which are referred to as the bronchioles, which then themselves branch into terminal bronchioles and alveoli. Remember, we have one trachea dividing into two main primary bronchi, left and right. Then we have now 5 lobar secondary bronchi, and these 5 lobar secondary bronchi, actually they are related to the 5 lobes, of course 2 lobes on the right and two lobes on the left, all right? Then now we have now the tertiary bronchi, where we have the right lung with around 10 tertiary, where the left lung has between 8 to 10, based on the anatomical variation that may be there. From there, we now have the smaller bronchi and the bronchioles. Then we have the terminal bronchioles that do give us the respiratory bronchiole. Then that terminates into the alveoli, ducts and alveoli. So averagely, we could be having around 23 generations to get to that level. So the trachea has major function. It furnishes open passages for air going into and from the lungs, and it does connect the larynx to the bronchi. Okay? All right, so we have that as our trachea. The larynx is here, our bronchi is there, so we should be able to appreciate. And that marks the end of the upper respiratory tract anatomy. Moving down and now focusing on the lower respiratory tract, majorly the lungs. So the lower respiratory tract consists of majorly the lungs, which contain the bronchial and alveolar structure needed for gas exchange. So we have them at that point. So the structures of the lungs are categorized into divisions and bronchial tree. So like we have the apex of the lungs, these are not the apex of the lungs, and it is the pointed upper part of the lungs. If you want to feel them on a patient, you have to locate them above the clavicles, okay, or the collarbone. Then you have the base. The base is around here, and the base is the broad and inferior surface of the lungs here. The lobes, we are saying that there are 3 lobes on the right and 2 lobes on the left. You can appreciate this one: superior lobe, middle lobe, inferior lobe. On the left, we have superior lobe and the inferior lobe. So we can try and focus on some of these lobes that you're talking, like the right upper lobe. This is the right superior lobe, like you have here, right? This one will extend from the apex of the lung to the 4th rib anteriorly and to the 5th rib posteriorly. Then next we have now the right middle lobe, all right? So this one is what is referred as the middle lobe, and it's here, guys. It extends, this one is located anteriorly between the 4th and the 6th rib. So this one can only be accessed anteriorly, okay? While the upper right, you can access it both anteriorly and posteriorly. Next, we have now the right lower lobe. This is the inferior lobe here. You can be able to see it here. This one extends from the 6th rib anteriorly and laterally to the 8th rib, and from the 5th rib posteriorly to the diaphragm. Then now we have the left upper lobe. The left upper lobe, it's here, this superior lobe here. This one extends from the apex of the lung to the 6th rib anteriorly and includes the lingular tongue-like projection near the cardiac notch, right? Okay, that we have here. Then now we have the left lower lobe, which is here, this inferior lobe. This one extends from the 6th rib anteriorly to the 8th rib laterally and to the diaphragm posteriorly. The other parts, we have the roots, the hilum, and the other parts. So the hilum consists of the pulmonary artery, the bronchus, the pulmonary veins, the nerves, and the lymphatics. We can be able to appreciate all these on our diagram. So when you look at the structure of the lungs, there is an exchange and diffusion of gases in the lungs normally takes place over approximately 3 million alveoli and the alveolar capillary membrane. So the alveoli Also contains a coating substance that is a phospholipid that is a surfactant, and this surfactant normally reduces the surface tension and keeps the alveoli open from collapsing. Surfactant is a lipoprotein complex and is normally produced by the type 2 alveolar cells in the lung. It reduces the surface tension within the alveoli by preventing alveolar collapse, which could result in a condition referred to as atelectasis during exhalation. So by lowering surface tension, the surfactant ensures alveoli remain open and reduces the work of breathing. So when a patient is on a vent, a mechanical vent, we have problems with the surfactant, and what helps us keep the alveoli open is the PEEP. Okay, all right. So we have already talked of the bronchi, that's the left and right, the bronchioles, the alveoli. It's important to know that we have a dual supply of the lungs, where we have the pulmonary artery that will be carrying deoxygenated blood, and the bronchial arteries that carry oxygenated blood. So this is what nourishes the lungs, right? This is what nourishes the lungs, and this is what takes blood from the heart to the lungs for oxygenation. Based on that, we have some different chest configuration. Normally, we base on the anterior posterior diameter to the lateral diameter. So if you compare the anterior posterior to the lateral diameter, the ratio should be 1 to 2. However, there are 4 main deformities of the chest associated with respiratory disease that does alter this relationship. So we could be talking of the barrel chest, or the funnel chest, the pigeon chest, or the kyphoscoliosis. Starting with the barrel chest, notice the increase in anterior posterior diameter, right? This one has already altered the normal ratio, which is supposed to be 1 is to 2. So the barrel chest occurs as a result of overinflation of the lungs. There is an increase in the anterior posterior diameter of the thorax, and this normally happens in patients like those patients suffering from emphysema, where the ribs are widely spaced and the intercostal spaces tend to bulge on expiration. So the appearance of the patient with advanced emphysema will thus be very quite characteristic, and it often allows a nurse to detect the presence easily, even from a distance, because of the increase in anterior posterior diameter. The second abnormality is the pectus excavatum. It's also referred to as the sunken chest or the funnel chest. All right. So funnel chest occurs when there is a depression in the lower portion of the sternum. Right. So the sternum is growing inward. Okay, that's what we may be allowed to say. So this may compress the heart and great vessels, and this will result into symptoms like the murmurs. So funnel chest may occur in patients with rickets or the Marfan syndrome. The third one is the pigeon chest, and this is also referred to as pectus carinatum, and we can be able to appreciate pigeon chest, pectus carinatum, and that can be able to help us differentiate between that and pectus excavatum, which is sunken or the funnel chest. So in a pigeon chest, you find that there's a displacement of the breastbone. So the breastbone has been displaced outward, and there is therefore an increase in anterior posterior diameter. So this presentation is normally occurs in patients with the rickets, Marfan syndrome, and the kyphoscoliosis. The fourth one is the kyphoscoliosis, and the kyphoscoliosis is characterized by elevation of the scapula, and also a corresponding S-shaped spine. Okay, you can see the S-shaped spine. So this deformity limits lung expansion within the thorax. It may also occur in osteoporosis and other skeletal disorders that affect the thorax. So the lungs do regulate air exchange by concentration gradient. So in alveoli, you find that the gases move from an area of high concentration to an area of low concentration. So because the concentration of carbon dioxide is greater in the alveoli, it diffuses out of the lungs and it is exhaled. And because the lungs contain a greater concentration of oxygen, oxygen will diffuse out of the lungs into the alveoli to be carried to the rest of the body parts. So the alveoli provide a surface area large enough to allow rapid gaseous exchange. So we have two types of cells in the alveoli. You have type 1 and type 2. So for the type 1 cells, they form the walls, while the type 2 is they produce the surfactant that prevents collapse, the one that we just mentioned. So the pleura in the membrane covers the lungs and lines the thoracic cavity. The visceral pleura covers the lungs, while the parietal pleura lines the thoracic cavity. So we have the pleural fluid that does lubricate the pleura, and this reduces the friction during expiration. Okay guys, that marks the end of the anatomy. We can now shift our gears to the physiology of breathing. So in physiology of breathing, first of all, we have nerve stimulation. And nerve stimulation, the most important nerve here is the phrenic nerve, which normally activates the respiratory muscle, especially the main inspiratory muscle, which is diaphragm muscle. So when the muscle is activated, the muscle will contract, and the diaphragm will contract in a craniocaudal contraction manner. And also the external intercostal muscle will also contract. And when this happens, it leads to thoracic expansion. So the thoracic cavity enlarges, and this one increases the volume. And this is where now Boyle's law sets in. Remember, Boyle's law is a very important concept in chemistry and physics, which states that when the volume of a gas increases, there will be a corresponding decrease in pressure, provided the temperature is constant. So when when the volume has increased here, we're going to have a corresponding decrease in pressure according to Boyle's law. So pressure changes, we are going now to have drop in intrathoracic and intrapulmonic pressures. And this will allow the air to move into the lungs. So inspiration will be complete as air fills the alveoli. On expiration, the muscles are going to relax and the thoracic cavity volume is going to decrease, and based on the Boyle's law, the pressure is going to increase and air will be expelled from the lungs. In that case, we will say now the ventilation is complete. So we can also do the assessment of the respiratory system, and in assessment we have to get a detailed health history, we have to perform physical examination and carry out some diagnostic findings. So on health history, the assessment of the respiratory function using health history involves the use of the subjective data. So we explore the patient's symptoms through characterization and history taking to help anticipate the needs and plan care. So by considering these factors, we assess the dyspnea, the difficulty in breathing, we look at the chest pain, and of course, we characterize using the OPQRST mnemonic, and then we look at the cough, hemoptysis, the dyspnea, the associating factors, and the question that we have to ask just to see how severe this condition is. You also ask about the history, the patient history and family history of chronic lung diseases, chest pain, and also other associated symptoms like cough, hemoptysis. We have to know the difference between hematemesis and epistaxis. Remember, hematemesis is associated with the gastrointestinal system, while epistaxis is associated with the upper respiratory upper airway challenges. Okay, in terms of examination, we have to examine the patient's respiratory rate, the depth, the pattern, and also look at the anterior posterior diameter. Remember, we have to know that the anterior posterior diameter to the lateral diameter, it should be 1:2. So if that ratio is interfered with or altered, then it could suggest air trapping, like the ones that we found in a barrel chest for the emphysema patient. We can also assess the clubbing of the fingers, central cyanosis, jugular veins distension, and also the tactile parameters. In terms of diagnostic tests, we could carry out the bronchoscopy, chest X-ray, pulmonary angiography, sputum study, thoracocentesis, pulmonary function tests, arterial blood gas analysis, lung scan, Montus intradermal skin test, laryngoscopy, lung bioscopy, blood biochemistry, and hematologic and coagulation factors. Starting with the bronchoscopy, where it involves the use of a bronchoscope, all right, to directly visualize the trachea and the bronchial tree. So during the bronchoscopy, the physician will take the biopsies and perform some deep tracheal suctioning and remove foreign substances. So as a nurse, you have to ensure that you are withholding food and fluids for 6 to 8 hours if possible, and make sure that the written and informed consent has been signed. This test could predispose the patient to some complications like the bleeding, defection, pneumothorax, bronchoscopy, hypoxemia, a cardiac complication like arrhythmias, fever, throat and hoarseness, and six other conditions. So in terms of managing, you have to do the pre-procedure assessment so that we have careful assessment of the patient medical history and the current health status to identify any risk factors. You have to do continuous monitoring of the vital sign, oxygen levels, and cardiac function during the procedure, and you have to ensure the skill is being performed by an experienced physician, right? So that we limit the amount of complications that we might predispose the patient to. The next test is the chest X-ray. This produces a radiographic picture of the lung tissue, and it can help us detect tumors, inflammation, air fluid in and around the lungs. All right. It can also be used to monitor the equipment such as catheters and chest tubes. Consider the following action when taking an X-ray. You have to determine the patient's ability to inhale and hold his breath, because this is what they are going to do during the procedure, and you make sure that the patient removes any jewelry before the X-ray is done. So now we know that the air will be opaque. So when we are trying to visualize and where we have here, we are going to have this dark discoloration, and that will be all right. And then now we have our heart, right? We have our heart in this region. So the rest now we have the lungs. Okay, so we can be able to see that, like in lobar consolidation, diffuse consolidation, multifocal ill-defined, atelectasis, where we have the lung collapse, the fine nodule, solitary pulmonary nodule, fine reticular interstitial, coarse reticular interstitial, and multiple masses. Like you can see, of course, we have the normal lung, and then we have now look at now the pneumothorax, right, where there's air in the pleural cavity, right? This becomes a defining feature for pneumothorax. Notice for the pneumonia, so we have the affected lung, where now instead of the opaque sign, it is not there, okay, and that gives us an opportunity for that kind of diagnosis. What about for lung cancer? Okay, and notice the markings throughout. That gives us that diagnosis. We also have the pulmonary angiography, where the patient is going to receive an injection of a radio opaque dye through a catheter. So this provides a radiographic picture of pulmonary circulation. You have to consider the following. You have to note in patient of the allergies because it's going to receive an injection, right? So you have to notice that allergies to iodine, seafood, radio opaque. Okay, so those who are allergic to such, they could be given antihistamines before the process. Also, we withhold food and fluids for 8 hours to avoid aspiration, and make sure that there is written informed consent has been obtained to avoid unnecessary legal issues. Inform the patient about the possibility of flushing of the face and the burning in the throat because this is an expected side effect of this condition, right? So we have the angiography. Generally, angio, we are looking at blood vessels, so we are visualizing the blood vessels. So pulmonary, we could be concentrating in the lungs, or the cardiac for the cardiac for the heart. Okay. Another test is the sputum study. So these are laboratory tests that provides a microscopic evaluation of the sputum, evaluating it for the culture and sensitivity, gram stain, and acid fast bacillus. So you have to obtain an early morning sterile specimen from suctioning or expectoration, and make sure the specimen is truly sputum, not saliva, before sending it to the lab to avoid false results. So sputum is obtained by coughing and is normally examined in the lab. Okay, sputum is also known as the phloem. So it's a thick type of mucus that is made in your lungs, and that is what we want for examination. Thoracentesis is another test. So here a needle is used to remove fluid from the pleural space, or to obtain a sample of intrapleural fluid to determine the cause of an infection or emphysema. It is performed using a local anesthesia. So just make sure the consent is there, reassure the patient, and try to position the patient in the best position possible for us to have the maximum results. During the procedure, you have to monitor the patient's respiratory status, you have to monitor the patient's vital signs, and after any invasive tests involving airway or such as the bronchoscopy, assess the respiratory status to ensure the patient's safety. And patients who are allergic to iodine or seafood are at risk of reaction, so you have also to be aware of that. Of course, identifying the landmark, the xiphoid process, and the fifth and the fourth grips is help in selecting a site for needle insertion. But the most commonly used, we have the left sternal costal margin and the sub-xiphoid approach in this. Pulmonary function tests. These are non-invasive tests that measures lung volume, ventilation, and diffusing capacity using a spirometry. So the patient breathes through a mouthpiece through a specific direction, and then a computer then calculates the volumes. So you have to tell the patient to refrain from smoking and or eating a heavy meal for 4 to 6 hours because this can lead to wrong results, false results, and you have to document if they're using bronchodilators or opioid because this can interfere with the results also. ABGs, these are tests that uses the arterial blood for tissue oxygenation, ventilation, and acid-base status. So you have to consider the following. You have to know the patient's temperature, you have to document oxygenation and mechanical ventilation, and you have to hyperonize the syringe you will use to the sample to sample the arterial blood sample to prevent coagulation. Also need to apply pressure to the site for at least 5 minutes for an extended period. If this guy is having a coagulopathy, then it will be an extended period. Assess the puncture site for bleeding or hematoma formation, and then maintain a pressure dressing for at least 30 minutes. Remember to monitor circulation distal to the puncture sites. For the lung scan, a lung scan or a ventilation perfusion VQ scan, it uses inhalation or an IV injection of the radioisotopes to create an image of blood flowing through the lungs. So you have to note the patient also allergies and make sure that you have informed consent, instruct the patient to remove all the metals before the procedure, and confirm the patient is able to lie still about an hour during the procedure. Also check the catheter insertion for bleeding and for bleeding after the procedure. So lung scan can be able to see lung cancer has been revealed using the CT scan procedure. The Mantoux test, the patient is going to receive an injection of tuberculin to detect tuberculosis, TB antibodies. So you have to document any dermatitis or rash. You have to document exposure to bacilli, immunization, and you have to circle the test site and note it in the patient's record, and note the date and time for a follow-up following 48 to 72 hours after an injection, right? So we have several indications for skin test screening for tuberculosis according to CDC. Like individuals with signs and symptoms suggestive of tuberculosis, they have to be subjected to this one to ascertain. And recent contacts of person known or suspected to have tuberculosis, just to see if they have contracted the disease. Persons with undiagnosed upper lobe fibrotic lesions, persons with infected who have been infected with HIV, the alcoholics and intravenous drug. All these are people who are at risk of contracting the tuberculosis. Laryngoscopy uses a laryngoscope to directly visualize the larynx, right? So you just try and make sure that there is a written consent and withhold food for 6 to 8 hours and explain that the patient will receive a sedative to promote relaxation. Okay. So some of the findings, you could find that the larynx maybe it's red, irritated, or small laryngeal ulcers, or the pseudocalmas, the granulomas in the larynx, which could be very key in diagnosing a patient. Lung biopsy involves the removal of a small amount of lung tissue for histological evaluation. So lung biopsy may be done by a surgical exposure of the lung, or that could be an open biopsy, or by endoscopy, that is using a needle designed to remove a core of lung tissue. So we're just doing this biopsy to confirm a clinical impression of a lesion, or when an inflammatory lesion is not responding to conservative therapy after 10 to 14 days, or for determination of a more definitive treatment of that lesion. Okay, that should help. In, in blood biochemistry, we do assess a blood sample for potassium, sodium, calcium, phosphorus, glucose, bicarbonates, the blood, urea, nitrogen, creatinine, protein, albumin, osmolarity, and the alpha-1 antitrypsin. You have just to ensure that you're withholding food and before the procedure, and you're checking the site for bleeding after the procedure, and you can be able to see some of the parameters that are involved in assessing that. So a blood sample can be used to analyze the red blood cells, or white blood cells, thrombin time, the INR, the partial thromboplastin, is the erythrocyte sedimentation rate, the platelets, hemoglobin, and the hematocrit, right? Okay, guys. So management of patients with upper respiratory disorders, we could have upper respiratory airway infections, obstructions and trauma of the upper respiratory tract, or even cancer of the larynx. So we have a number of disorders that does affect the upper respiratory tract. Sinusitis, we said, is the one that is more associated with the paranasal sinuses, and it's majorly the inflammation of the sinuses. It could be acute, chronic, viral, bacteria, fungal in origin. As for the acute sinusitis, find that the sinuses which are the mucus-lined cavities, they be filled with the air that drain normally into the nose and are involved in high proportion of the upper respiratory tract infection. So if these openings into the nasal passages are clear, the infection resolves promptly. However, if the drainage is obstructed by a deviated septum or by a hypertrophied turbinate, spurs, or nasal polyps or tumors, nasal infection may persist as a smoldering secondary infection or progress to an acute suppurative infection causing a purulent discharge. As for the chronic sinusitis, the inflammation, the sinuses will persist for more than 3 weeks in an adult or 2 weeks in a child. In terms of pathophysiology, find that acute sinusitis results from unresolved rhinitis, spreading infection of the paranasal sinuses. So we have the swollen nasal concha blocking the sinus openings, causing marked inflammation, congestions with thickened mucus secretions which fill the sinus and occluding the opening. As for the chronic sinusitis, this is persistent narrowing and obstruction of the frontal, maxillary, anterior ethmoid, and prevents this prevents the adequate drainage of the nasal nasal passages.